Dr. Hussain, we're going to spend most of this conversation talking about advanced prostate cancer. But before we move on, would you give us a brief overview of the stages of prostate cancer?
Absolutely. So with any cancer, there's we count sort of four stages. But I would say in prostate cancer, the biggest thing is when the cancer is newly diagnosed, which could be confined to the prostate or locally advanced, meaning the cancer has gotten outside the capsule of the prostate, but still within that pelvic region. There is the group of patients who have pelvic lymph nodes and at time of diagnosis. And of course, there is the patients who have systemic disease, which would be technically stage 4. Now, the systemic disease implies any abnormality that is found on scans that is beyond the pelvic region. And so that could be lymph nodes in the back of the belly, that could be thoracic lymph nodes, that could be neck nodes, that could be lung lesions, of course, or bone or liver. Now, the most common area where the cancer goes to is really when we talk about metastatic disease is the bone. And then lymph node is another area where the cancer goes to. Prostate cancer that is confined to the prostate is curable in the vast majority of patients. There is a category of men who undergo surgery or radiation, and then their PSA begins to go up afterwards. And this is what we call biochemical relapse. And this is a situation where we know that in all likelihood, obviously, especially if the patient had their prostate out, that the cancer is spread. Yeah. With the current imaging, a good chunk of times we do not find anything because we're able to pick up PSA that goes from undetectable to 0.2 to 0.3, but there's not enough cancer to show up on the scans. We're hoping, obviously, the better scans, the PET oxymin scan, the PSMA scans are going to help us to identify sites of metastases. But this is a group of men where if there's no cancer visible and the only thing we're dealing with is PSA that's gone up, if they've had surgery, then there's room for what we call salvage therapy with radiation and hormonal treatment. The case is a bit different if there's only just the prostate, if radiation was given previously. And of course, we talked about metastatic disease.
Once someone has been diagnosed, what tests are used to help understand the aggressiveness of their disease and their overall prognosis?
Well, I think there's different basic things, as in what was the extent of the cancer, how did it look under the microscope, and what is the PSA level. So these are the general things. There are different sort of genomic panels that the urologist will use to kind of decipher and other things to kind of help with figuring out aggressiveness and things like that. What I would say is this, is a patient who is diagnosed and has a cancer, and at a minimum has what we consider a Gleason 7 prostate cancer. So that's the scoring system, that is done with the original Gleason score, or the new patterns where it's talking about intermediate risk to high risk. To me, this is a cancer that needs to be treated. And again, of course, that's all to do with if a person has other comorbidities, they are, have some other terminal condition, that's a separate story. But talking generically, that would be when we would recommend. And these are the patients that are generally not seen by the medical oncologist. They're seen by the urologist. And then they can refer them to radiation oncology also for consultation.